So the next chapter in arrhythmias is tachycardias. Tachycardias are nothing but they represent increased heart rate more than 100 per minute. They are nothing but run of premature beat more than 3 or 6 consecutively. So they are extension of premature beat. So the premature beats are going to occur continuously without intervening sinus beat. It can be a tachycardia. So just like we classified premature beats, naturally because the tachycardias are extension of premature beats which are running continuously, once again the same classification can be applied to tachycardia, namely atrial tachycardia, junctional tachycardia, ventricular tachycardia. So just like premature beat, because they are extension of premature beat, they represent increased irritability of the heart. So this is what the tachycardia is about. So you have a premature beat here, and the premature beat is running continuously for more than 3 beats. So if it is running more than 3 beats, it forms a tachycardia. So it forms a tachycardia. So there are 2 main mechanisms of tachycardia. One is called the reentry, a mechanism where because of the unidirectional block, a single impulse goes through a pathway round and round, producing very rapid circuit and resulting in a tachycardia. So this is a reentry tachycardia, most often happens in a normal hearts. So reentry tachycardia is a classical example of AV nodal reentry tachycardia or atrioventricular reciprocating tachycardia. So these are the very common reentry tachycardias, most common tachycardias, and they most often occur in the presence, especially in the supraventricular tachycardia. They most often occur in normal hearts. Whereas the tachycardias can be due to abnormal firing of a single automatic focus or ectopic focus. A single ectopic focus either in the atrium or in the junction or the ventricle rapidly firing. A single focus rapidly firing is called automatic tachycardia. So most often these automatic tachycardias are primarily occur from a diseased hearts. Majority of time reentry arrhythmias are most often in normal hearts. Automatic tachycardias are most often in diseased hearts. So automatic tachycardias will have long RP interval. I will tell you about the RP interval. The reentry tachycardias will have short RP intervals. When you give a carotid sinus massage, automatic tachycardia, you can only control the heart rate, but not convert the arrhythmia into sinus rhythm. Whereas in a reentry arrhythmia, most often carotid sinus massage will convert that into sinus rhythm. Once again, when there is an intermittent VPD, the tachycardia will be reset by the ventricular premature beat. The VPDs will terminate the reentry tachycardias most of the times. The drugs like digoxin, verapamil or beta blockers will only reduce the heart rate and will not convert the arrhythmia to sinus rhythm in automatic tachycardia, because most of the time the drugs like adenosine, intravenous verapamil or amiodarone will restore sinus rhythm in a reentry tachycardia. Automatic tachycardia most often occurs in diseased hearts, whereas reentry tachycardia occur in normal hearts. So the other important long-term treatment like radiofrequency ablation, in automatic tachycardia you have less response or you have less favorable result from radiofrequency ablation. Here you will have a very excellent result or permanent remedy from tachycardia if it is due to reentry tachycardia and you do radiofrequency ablation. It is very difficult to get normal sinus rhythm because most often this occurs in basically diseased hearts. So the basic disease has to be treated to get the sinus rhythm here. Easy to get sinus rhythm here because of basically structurally normal heart. So here automatic tachycardia is most often easy to diagnose, but reentry tachycardia, you can diagnose reentry, but the mechanism of reentry, where the reentry is happening, is little bit difficult in reentry tachycardia. So these are the differences between automatic tachycardia and reentry tachycardia, 2 main mechanisms of a tachycardia. So you can either classify tachycardia according to the site of origin. Sinus tachycardia, atrial tachycardia. Atrial tachycardia can be atrial tachycardia, atrial flutter and atrial fibrillation. Then junctional tachycardia, ventricular tachycardia, ventricular flutter and ventricular fibrillation. So this classification is according to the site of origin. But common classification is like this. The common classification or the working classification of tachycardia is whether the tachycardia has got narrow QRS or the tachycardia has got wide QRS. Narrow QRS tachycardia is defined as the QRS duration less than 0.12 second. White QRS tachycardia described as a QRS more than 0.12 second. So this is a working classification. Although we can classify according to the site of origin, working classification is narrow QRS and wide QRS. First, we look at narrow QRS complex tachycardia. So what are the prerequisites to diagnose narrow QRS tachycardia? First is tachycardia, which means heart rate more than 100 per minute. Either atrial rate or ventricular rate more than 100 per minute is atrial tachycardia. Either the atrial rate or the ventricular rate or both more than 100 is tachycardia. Here the QRS is less than 0.12 second. So narrow QRS tachycardia can be divided into regular narrow QRS and irregular narrow QRS. Regular narrow QRS can be sinus tachycardia, atrioventricular reentry tachycardia AVNRT, or atrioventricular reciprocating tachycardia utilizing accessory pathway, atrial flutter and atrial tachycardia. So these are the examples of regular narrow QRS complex tachycardia. Atrial flutter can come under regular tachycardia if the AV conduction is constant. If the AV conduction is variable, it can also come under irregular narrow QRS complex tachycardia. The most common cause of irregular narrow QRS complex tachycardia is atrial fibrillation. And of course, atrial flutter with a variable conduction of atrioventricular node. So, variable conduction of atrial tachycardia, which is very rare. But the most other important tachycardia in irregular narrow QRS complex tachycardia is a multifocal atrial tachycardia. So, the two important things you must know about narrow QRS irregular tachycardia is atrial fibrillation and multifocal atrial tachycardia. So, whereas you have to learn about all the 5 things here in a regular narrow QRS complex tachycardia. So, the commonest cause of regular narrow QRS complex tachycardia is sinus tachycardia. So, we go through the steps. Here, we first identify tachycardia because heart rate is more than 100. Then we look at the QRS width. Yes, it is narrow. So, it is a narrow QRS tachycardia. Then we look at RR interval, and throughout the ECG, the distance between 2 successive R waves are constant. So, that's why it is regular narrow QRS tachycardia. So, in a regular narrow QRS, narrow VPD, in a premature beat, narrow QRS premature beat, what did we see in front? Whether the P wave is there in front or not. So, in this tachycardia also you have to see whether the P wave is in front or not. Yes, there is a narrow QRS regular tachycardia. In front of the QRS, I see the P wave. So, once you see the P wave in front of the narrow QRS tachycardia, it can be a sinus tachycardia or it can be atrial tachycardia. So, why we say it is a sinus tachycardia? The P wave which is preceding the QRS is looking like sinus P wave. Its configuration is normal. It is less than 2.5 in height, less than 2.5 in width. It is positive in L1, negative in AVR, biphasic in V1. So, because all the characteristics of the P wave is coming from sinus is there, this is a tachycardia, narrow QRS, regular tachycardia, but sinus tachycardia because the P wave preceding the QRS is a sinus P wave, the P wave produced by the sinus node. So, sinus tachycardia is most common, but it is the most difficult arrhythmia to treat. It is the most common arrhythmia, most easily diagnosed arrhythmia, most difficult arrhythmia to treat. Because sinus tachycardia, you should not treat the sinus tachycardia per se. You have to treat the secondary, you have to treat the basic cause of sinus tachycardia because many times sinus tachycardia is secondary to something else. It may be anemia, anxiety, bronchial asthma, cardiac failure, drugs, exercise and emotion, fever, thyroid, hypoxia, hypotension. Sometimes on seeing you itself, the patient may have a sinus tachycardia because of anxiety. So, as far as sinus tachycardia is concerned, we cannot say this antiarrhythmic drug is used for sinus tachycardia. What is very important is to treat the basic cause which is causing sinus tachycardia. So, straight away, don't try to give a beta blocker or a rapamyl to suppress sinus tachycardia. Many times, the sinus tachycardia will be compensating for a major disease like heart failure or hypoxia or hypotension. So, this may be a compensatory mechanism by which the body is maintaining or the heart is maintaining the cardiac output. So, whenever the stroke volume is low, the sinus tachycardia is the one which maintains the cardiac output. So in that situation, if it is compensated tachycardia and suppress it, the patient will go for a severe hypotension and shock. So please remember, whenever you come across a sinus tachycardia, identify what is causing sinus tachycardia and treat the cause and not the arrhythmia per se. Then we come to the next important cause of narrow QRS complex tachycardia. So once there is RR interval is constant and regular, you are diagnosing, and the QRS is narrow. Once again, you are diagnosing narrow QRS complex tachycardia. So just like we divided the narrow QRS premature beat into atrial premature beat and junctional premature beat, how did we do that? Once again, we saw whether there was a P wave in front of the QRS is atrium. If there is no QRS, there is no P wave in front of the QRS, it is junction. So similarly, in the tachycardic QRS beats, if you see in front of the tachycardic QRS beat, if you have a P wave and the P wave is looking abnormal and you think this P wave is not coming from the sinus, it is likely to be atrial tachycardia. If there is no P wave in front of the QRS, it is likely to be junctional tachycardia. So these are the mechanisms of tachycardias, narrow QRS complex tachycardias. So there are two reentry tachycardias. AV node reentry tachycardia, the reentry is happening within the AV node. Whereas atrioventricular respiratory tachycardia, the reentry circuit involves an accessory pathway. So this is an accessory pathway involving reentry. AV node itself as a reentry mechanism, AVNRT. A single atrial focus firing rapidly is paroxysmal atrial tachycardia. So in a junctional tachycardia, there is a simultaneous retrograde activation and the antegrade activation. So you will not have the P wave in front of the narrow QRS complex tachycardia. Whereas in a atrial tachycardia, you will have abnormal P wave in front of the QRS of the tachycardia. And the atrial flutter is because of macro reentry circuit within the right atrium. Anti-clockwise is a typical flutter. So it happens within the right atrium is atrial flutter. So these are the mechanisms of various narrow QRS complex tachycardia. So now we come to the junctional tachycardia. So how are we going to diagnose tachycardia? When there is no P wave preceding the QRS complex, and this is the most common arrhythmia in normal hearts. So we go to the steps. So first we identify the tachycardia, heart rate is more than 100. Then we look at the QRS duration, it is narrow. Then we look at the constancy of the RR interval, it is constant. So this is narrow QRS regular tachycardia. Then what you have to see is in front of the QRS. In front of the QRS, I don't see a P wave. Because I don't see a P wave in front of the QRS, this is likely to be junctional tachycardia. Supraventricular tachycardia, but junctional tachycardia. Once you decide it's a junctional tachycardia, then you have to identify the mechanism. Here comes the difficulty. So now you know that tachycardia is coming from the junction. But most of the junctional tachycardias are because of the reentry mechanism. The reentry may be happening within the AV node, or it may utilize an accessory pathway, and the accessory pathway form one limb and the AV node will form other limb of the reentry circuit. So it is very important to differentiate between these two in a patient who has got narrow QRS complex regular tachycardia, in which the P wave is not there in front of the QRS. So in AV node reentry tachycardia, the reentry circuit is happening within the AV node. So within the AV node, the reentry circuit is happening. So what is the mechanism of reentry? Normally, whenever an impulse is finding an abnormal tissue, what will happen is it will go around the tissue to reach the distal myocardium. It will go around the tissues. So definitely this is a basic reentry mechanism. But what happens in AV node is, AV node in some people may have two types of pathway. One is a fast pathway, another is a slow pathway. The fast pathway is conducting fast, slow pathway is conducting slowly. What happens is, this patient who has got the two pathways, the fast pathway will come and depolarize the ventricle, and also it will go into the slow pathway and stop the slow pathway impulse coming once again back into the ventricles. So this is what happened in a normal reentry circuit. As far as the patient is in sinus rhythm, there is no problem, because the sinus beat will keep on coming on both the limbs and be going to the distal path. So this is what happens when there is a sinus problem. So here it is a slow pathway and it is a fast pathway. So once again you can see the slow pathway and this is a fast pathway. Fast pathway is the one which goes to the ventricle to depolarize, and it also goes into the slow pathway limb and block it. So this is what happens in a normal sinus rhythm. In one more thing you have to understand is that the fast pathway will have a longer refractory period, whereas a slow pathway will have a shorter refractory period. The fast pathway conducting impulse fast, but it has got a longer refractory period. Slow pathway will have conducting impulse slowly, but it has got a short refractory period. So as I told you, as long as the patient is in sinus rhythm, no problem. But let us say the patient has got a premature beat. Let us say the patient has got atrial premature beat, which is going to precipitate a reentry circuit. Because the atrial premature beat is appearing early or coming early, at this point, because it is coming early, because sinus beat is coming at a particular interval, both pathways would have recovered. So the impulse goes to the fast pathway and then the slow pathway and so on. But if the impulse is coming very early, because of the shorter refractory period, the slow pathway would have recovered, but the fast pathway would not have recovered because of the long refractory period. So what the reentry circuit will be do is, the impulse will go through the slow pathway and then retrogradely go back to the fast pathway. By this time, the fast pathway would have recovered. So it will form a rapid reentry circuit with a very fast heart rate going into the ventricle. So this is called slow fast pathway. Slow pathway means slow pathway antigradally conducting and fast pathway is retrogradely conducting. So fast pathway retrogradally conducting will go back and depolarize the atrium, and slow pathway is the one which is coming to the ventricles to depolarize the ventricle. So this is how the reentry circuit is precipitated, and the common reentry, the type or typical AVNRT. Typical AVNRT will have a slow pathway conducting antigradely and fast pathway conducting retrogradely. So because of that, so when the slow pathway is conducting antigradely, so you get the QRS complex. Because the fast pathway is conducting rapidly to the atrium, the P wave will be inside the QRS complex. So in a typical AVNRT, you may not see a significant P wave in front of the QRS or at the back of the QRS. So you will have only the QRS with no P wave in front, because the retrograde P wave is going rapidly through the fast wave to the atrium. So atrial depolarization and ventricular depolarization will occur simultaneously. So here you can see the tachycardia here. So one is tachycardia, second is narrow QRS, third is regular, and I see a P wave in front, no P wave in front. So it is likely to be junctional tachycardia. So in junctional tachycardia, I don't see a retrograde P wave in the ST segment here. So because of that, I assume that antegrade ventricular conduction and retrograde atrial conduction is happening simultaneously, because slow pathway is conducting anterogradely to produce QRS. Fast pathway is conducting very fast to the atrium to produce the P wave at the same time as the QRS. So this is a typical AV nodal reentry tachycardia. So ECG itself will tell you the mechanism of reentry here. The mechanism of reentry is AV nodal reentry tachycardia. So this is how AV nodal reentry tachycardia. Typical AVNRT will not have a P wave in front or will not have a P wave, retrograde P wave. So retrograde P wave, you have to look at the inferior leads. You must carefully look at the inferior leads, because retrograde P wave means the P waves are going up, so they will be inverted in inferior leads. So how to recognize a retrograde P wave? The P waves will be inverted in inferior leads. So look at L2, L3 and A wave, especially AVF. You find that the ST segment is not disfigured by the presence of a retrograde P wave. So this is likely to be AVNRT. So what happens when there is an accessory pathway like the Kent pathway? So here it is atrioventricular reciprocating tachycardia. Here the reentry circuit is utilizing the accessory pathway. In a narrow QRS tachycardia produced by the accessory pathway, antegrade conduction is through the normal pathway and retrograde conduction is through the accessory pathway. So reentry circuit is normal conduction through the accessory normal pathway. Antegrade conduction through the normal pathway means, because the antegrade conduction through the normal pathway or conduction system, you have a narrow QRS complex tachycardia. Because the retrograde conduction is going through the accessory pathway, that means the P wave, the retrograde P wave, the retrograde atrial activation will occur little more later than the antegrade ventricular activation, because the impulse has to go to the accessory pathway, then travel back to the atrium. So, your retrograde P wave in inferior leads will be little later than the ventricular depolarization, which means you will find the inverted P wave in ST segment in atrioventricular reciprocating tachycardia, telling you that retrograde atrial activation is occurring late. Why retrograde activation is occurring late? Because it is an accessory pathway conducting the impulse retrogradely. It takes little more time to activate the atrium when compared to the antegrade ventricular activation. So, whenever the accessory pathway is conducting retrogradely and antegrade conduction is conducting antegradely, the ventricular activation is occurring antegradely through the normal pathway. This is called orthodromic tachycardia. This is a classical orthodromic tachycardias or narrow QRS complex tachycardia, because the antegrade conduction is happening through the normal pathway and retrograde conduction is going to go through the accessory pathway. So, whenever this is happening, you will have a narrow QRS complex tachycardia, reentry tachycardia, and this is called orthodromic tachycardia. So, here this is what the concept you have to understand. So, in AVNRT, what has happened is the slow pathway is conducting anterogradely and fast pathway is conducting retrogradely. Because of that, my antegrade ventricular activation and retrograde atrial activation are occurring simultaneously. So, I will not have a P wave in front, I do not have a P wave at the back, a P wave at the back. So, this is a typical AVNRT, not AVRT, AVNRT. So, here I showed the example of ECG here. So, there is no P wave in front, especially you look at inferior leads, the ST segment in inferior leads is not disfigured. So, it is unlikely to have a retrograde P wave here. So, it is happening, retrograde P wave happening simultaneously with the QRS complex. So, in this mechanism we identify as AV node reentry. Whereas, orthodromic tachycardia of Kent bundle, what will happen is antegrade conduction will be happening through the normal pathway, resulting in a narrow QRS complex tachycardia, but the retrograde P wave will take little more time to activate the atrium, because it has to go through the accessory pathway, then travel to the atrium to depolarize retrogradely. So, in the ST segment, you find the inverted P wave in the ST segment after the QRS in atrioventricular reciprocating tachycardia because of the accessory pathway. So, during the tachycardia itself, you will know the mechanism of reentry. You know the mechanism of reentry is utilizing an accessory pathway whenever you find the retrograde P wave in the ST segment. So, look at here. So, this is what happening here. So, this is a normal Kent bundle. What happens normally is normal conduction is through, usually when there is a sinus rhythm, normal conduction will happen through the normal pathway as well as through the accessory pathway, resulting in a short PR with a delta wave I explained yesterday. So, this is what will happen. So, this is what the normal conduction is happen. For example, when we have a premature beat and the premature beat is going to block one of the pathways, the reentry circuit will be precipitated. So, the reentry circuit of antidromic tachycardia is the one where the antegrade conduction is happening through the normal pathway and retrograde conduction is going to happen through the accessory pathway. So, because antegrade conduction is going to go through the normal pathway and it is a narrow QRS complex tachycardia, whenever the accessory pathway is conducting retrogradely, it is called orthodromic tachycardia, which will always most often result in a narrow QRS complex tachycardia. So, now look at the ECG. First, we identify a tachycardia, narrow QRS, regular. So, is there a P wave in front? There is no P wave in front. So, that means it's a junctional tachycardia. Then we have to understand the mechanism. So, I carefully see whether there is an inverted P wave in my inferior leads. Look at the L3. So, in L3 you saw this is a T wave. In ST segment, you clearly see that inverted P wave is happening. So, that means the retrograde activation has taken little more time than the antegrade ventricular activation, and it is inscribed in the ST segment of the tachycardic complex. So, because the retrograde P wave is there in the ST segment, the mechanism of this junctional tachycardia is likely to utilize the accessory pathway, which is conducting retrogradely, and because of that, the atrial activation, retrograde atrial activation is occurring little later than the antegrade ventricular activation. So this presence of retrograde P wave in the ST segment may tell us the mechanism of this junctional tachycardia, the mechanism of reentry in this narrow QRS tachycardia is likely to be atrioventricular reciprocating, utilizing the Kent bundle to conduct the impulse retrogradely. That's why this is called orthodromic tachycardia, because antegrade conduction is occurring through the normal pathway or normal conduction system. What are the differences between AVNRT and AVRT, atrioventricular reciprocating tachycardia, utilizing accessory pathway? Most often AVNRT is in elderly, AVRT is because of the congenital accessory pathway. It can happen in young, most often women here, most often both it can happen. So because the AVNRT, there is a simultaneous atrial and ventricular activation, simultaneous atrial and ventricular contraction. So whenever there is a simultaneous atrial and ventricular contraction, you will have what is known as a Cannon wave. And for every beat, the atria are in the right atrium is contracting against closed tricuspid valve. So recurrently occurring Cannon waves will be present in AVNRT because both are occurring simultaneously, and you have a neck pulsation which is called regularly occurring Cannon wave will have a neck pulsation which is called frog sign. So here you can have syncope and family history of sudden death if the patient has got a very malignant arrhythmia due to AVNRT. There may be a small P wave in V1, a retrograde P wave in V1, which may show terminal R wave, but you can see that here the retrograde P wave will be present in the ST segment, indicating the R to P interval. The retrograde P wave interval is longer in accessory pathway mediated tachycardia. So that's why the P wave is appearing in the ST segment. Sometimes you can have a QRS alternance in AVRT, but this is not a very specific sign. And when you take after the conversion of rhythm to sinus, if you look at the ECG will show basic W2W pattern like short PR and a delta wave, which will confirm the tachycardia is probably due to reentry mechanism utilizing the accessory pathway. So why it is important to diagnose whether it is AVNRT or AVRT is because majority of your AVNRT will be terminated by your routinely used drugs like adenosine, metoprolol or verapamil, because all these drugs act on AV node and terminate your AVNRT. But only amiodarone is going to act on both accessory pathway and AV node. Sometimes you may require amiodarone because it is a drug which is going to also affect accessory pathway to convert the AVRT to sinus rhythm. So there is a very rare entity of what is known as atypical AVNRT. The atypical AVNRT is what this is a typical AVNRT where slow pathway is conducting antegradely and fast pathway is conducting retrogradely. So you have a P wave and QRS simultaneously. So that is your typical AVNRT. Whereas in atypical AVNRT, the antegrade conduction is through the fast pathway and retrograde conduction is through the slow pathway. Because the retrograde conduction is going to be very slow through the slow pathway, the retrograde P wave will be very much away from the QRS. Very much away from the QRS. It is not in the ST segment like AVRT, but is well away, clearing the T wave and well away from the QRS, because here the slow pathway is conducting retrogradely. This is called atypical AVNRT, and atypical AVNRT you can see in the inferior leads, you will find the retrograde P wave. But this retrograde P wave is not appearing in the ST segment like AVRT. It is appearing well after that T wave, and you have a very long RP P dash interval. P dash means retrograde P. The RP dash interval is much longer for AVRT, and this AVRT is usually very resistant to treatment, atypical AVNRT. So typical AVNRT is slow, fast. Antegrade conduction is through the slow pathway, retrograde conduction is fast pathway. Whereas atypical AVNRT is fast, slow. Antegrade conduction is through the fast pathway, but retrograde conduction is a slow pathway, which is very rare and which is very resistant to treatment. So the patient may have incessant tachycardias here, and many patients will need radio frequency ablation here. So this is, once again, we are showing an example of QRS alternates. You can see the QRS alternates. So sometimes the QRS alternates will appear in tachycardia, but also it is said the QRS alternates is a sign of pre-excitation related tachycardias. We can see in any narrow QRS tachycardia. Look at the retrograde P wave in inferior leads. You find the retrograde P waves are occurring close to the next QRS. That is, you have a very long RP dash interval in atypical AVNRT. Retrograde P wave will appear very long distance from the previous QRS. So it's a long RP dash. Some people call this a long RP dash tachycardia.